So now we will consolidate everything we've learnt so far by looking at some questions, and these are typical and reflective of those which may appear in the MRCP Part 1 exam and possibly in Part 2 as well.
Okay, let's do some questions now. Question 1 is, what is the most prevalent class of lupus nephritis? A1, B2, C3, D4, E5. And if you guys remember correctly, the most common class of lupus nephritis is class 4, therefore option D would be correct. Question 2 is, which combination of autoantibodies are most indicative of diagnosis of systemic lupus erythematosus if present? A, ANA URMP, B, ANA anti-Rho anti-La, C, ANA dsDNA anti-Rho, D, dsDNA rheumatoid factor, E, anti-Rho anti-La. So if you guys remember, we talked about really the necessity of having ANA with the updated guideline in order to be able to diagnose anyone with lupus. And if you also remember, I did talk about dsDNA and anti-Rho and La to be quite specific for lupus. Therefore, your option C, which talks about really all of them, would be the most appropriate in here. Question 3. A 30-year-old woman is newly diagnosed with SLE. She's planning a pregnancy soon. Her disease activity is currently stable aside from an intermittent malar rash when she spends a moderate amount of time outdoors. Which of the following drugs is most suitable for her? So this is basically trying to test your prescribing safety with cases of pregnancy. And if you remember, we talked about hydroxychloroquine to be the first line, and it is actually a safe drug to be continued during pregnancy in the cases of lupus. But as a recall, you will remember that anyone who has been on hydroxychloroquine for 5 years or more will need to have annual ocular screening according to the UK standards. Okay, let's do some questions now. A 40-year-old lady of African origin presents with red, scaly, annular lesions on her face and neck, which had got worse during a recent visit to Spain. She smokes about 20 cigarettes a day. Which of the following is the most suitable first-line management option for her condition? A, topical antibiotic. B, topical antifungals. C, smoking cessation, checking serum vitamin D level and applying high SPF sunscreen. D, short course of prednisolone. E, methotrexate. So if you go through this question logically, the stem should give you enough information that they're talking about an autoimmune condition, because you're dealing with a 40-year-old lady who's of African origin and is coming in with a scaly red lesion on her face and neck, which is a sun exposed area that has recently got worse after her visit to a sunny country. Therefore, really talking about antibiotic and antifungal is not going to make any sense in this case. So really you're left with options C, D and E. And if you think about it logically, you would be thinking about conservative measures and first-line steps before putting people on sort of stronger immunosuppressants such as methotrexate or oral prednisolone. So by definition and by sort of having a good exclusion criteria, even if you don't know the exact condition in here, which is, by the way, obviously cutaneous lupus, you should be able to get into a correct answer, which is option C, which is a smoking cessation, checking the serum vitamin D and supplementing as appropriate, and applying high SPF sunscreen. Question 2. A 30-year-old lady with cutaneous lupus has just given birth to a newborn boy. The newborn is found to have bradycardia and an ECG consistent with heart block. Which autoantibody is most likely to be responsible? This is quite a classic MRCP question, and the options that you've got in here is A, ANA or antinuclear, B, rheumatic factor, C, dsDNA, D, URMP, E, anti-Rho. So if you recall correctly, we did talk about the sort of the risk of mothers who have either SLE or cutaneous lupus and are found to have anti-Rho and anti-LA antibodies in their serum to be at risk of giving birth to newborns who could suffer from neonatal heart block, and this case is basically classically describing that. Therefore, the most appropriate option in here would be option E, or anti-Rho.
So now if we look at some questions. Firstly, which of the following investigative findings is typical of discoid lupus? ANA positive, deranged liver function tests, glomerulonephritis on renal biopsy, lymphocytic infiltrate on skin biopsy, or proteinuria on urine dip. So these are all findings that you may find in various autoimmune conditions, some of which we've discussed in previous videos. But you'll recall from a few slides ago that lymphocytic infiltrate on a skin biopsy is a typical finding in discoid lupus. So question 2. A 28-year-old African-American lady with a known diagnosis of discoid lupus presents to clinic. She is a non-smoker. She has tried conservative measures as well as intralesional steroids, but presents with a new scaly annular rash to her forehead. What is the most appropriate next step in her management? So the options are methotrexate, a trial of oral prednisolone, mycophenolate, leflunomide, or vitamin D supplements. So we can see from the vignette that firstly, she's a non-smoker, so that's good. If she was a smoker, we'd encourage her to stop smoking as part of the management. It says that she's tried conservative measures, so we can assume that she already protects herself from the sun and reduces sun exposure. And it also says that she's tried intralesional steroids, which is already part of the medical management. So really we're looking to see what can be used in the next step of her medical management, given that she appears to be presenting with a new lesion related to her discoid lupus. So the answer to this would be to trial some oral prednisolone, as you'll remember from the treatment algorithm previously.
So now let's do some questions. A 60-year-old male presents to his GP with worsening fatigue and arthralgia. He has a history of difficult to treat hypertension and has tried multiple drugs. In the last few months, he has recently started a new drug for his hypertension. The GP suspects a diagnosis of drug-induced lupus. Which drug is most likely to be the causative agent? So your options are A, doxazosin, B, nifedipine, C, bisoprolol, D, hydralazine, E, spironolactone. And if you recall correctly from our discussions earlier, you will realize that option D, or hydralazine, is the most classically associated drug with drug-induced lupus. It's really important to mention that some of the other drugs that are mentioned in the vignette have been associated with the cases of drug-induced lupus, and there are case reports on these. However, for the purpose of MRCP, if you have one of the drugs that I mentioned on the list originally as one of your options, I strongly encourage you to go with that option because those are the classic associated drugs with drug-induced lupus. Question 2, which antibody is most specific to drug-induced lupus? And the options are A, ANA, B, anti-dsDNA, C, rheumatoid factor, D, anti-URMP, E, antihistone. So you will remember from our talk earlier that the most specific antibody to drug-induced lupus is antihistone antibody. The remaining of the antibodies, you really should be completely familiar with them. ANA is the most sensitive antibody for the cases of SLE, and you need to have a positive ANA in order to be considered to have systemic lupus erythematosus. Anti-dsDNA is one of the most specific antibodies in the cases of SLE. And that, if you recall correctly from our lupus lecture, it goes hand in hand with antiphospholipid as well as anti-Smith antibodies. Rheumatoid factor is one of the antibodies that we look at in cases of rheumatoid arthritis, but it can be elevated in many other conditions. And anti-URMP is a very specific antibody in cases of mixed connective tissue disease that, again, you need to be familiar with for the purpose of MRCP.
So let's do some questions. So the first question talks about an 18-year-old female presenting to her GP with a history of the tips of her fingers, nose and ears turning white in the cold, followed by blue discoloration and then red on returning to the warmth. There is a history of similar symptoms in her mother and grandmother since childhood. She smokes 10 cigarettes per day. She's otherwise well. History and clinical examination reveal no evidence of a connective tissue disease. So what is the best first-line treatment for her? So from this description, it really impresses upon us the triphasic colour change. So we know automatically this is probably a diagnosis of Raynaud's disease. Given that she's so young and there's a strong family history and no other features of connective tissue disease, it's likely that this is a primary Raynaud's presentation. So the options are methotrexate, nifedipine, bisoprolol, smoking cessation, and advise the use of gloves, and sildenafil. So the correct first-line treatment here is smoking cessation and the use of gloves. The use of nifedipine may be indicated if that then does not work, but really the important thing to mention to this lady is to try and stop smoking and try and keep her fingers warm. Second question, which of the following diseases is least likely to be associated with Raynaud's phenomenon? So our options are rheumatoid arthritis, systemic lupus erythematosus, systemic sclerosis, gout, and myositis. So some of these conditions we have talked about in previous videos, some of which are going to be talked about in later videos, but you may know about them from your own reading. 4 of them are connective tissue diseases or autoimmune diseases, but option D is gout, and that is not associated with Raynaud's phenomenon. It should be stressed that not all autoimmune conditions are associated with Raynaud's, but the ones that are listed there can, to a lesser or greater extent, feature Raynaud's phenomenon in patients who are affected by them. So now let's do some questions. Question 1. A 30-year-old female presents to the rheumatologist with a history of new onset Raynaud's phenomenon, arthralgia, calcinosis on her digits and sclerodactyly. She is a smoker. Her GP has advised her to stop smoking and has previously prescribed her nifedipine for Raynaud's. Which other symptoms is she most likely to have in addition to the above? So we've got here a 30-year-old female, so she's a little bit on the older side for a primary Raynaud's phenomenon, you'll remember from the previous video. And she's got this new onset of Raynaud's phenomenon, as well as arthralgias, calcinosis and sclerodactyly. So she's clearly got some features that might make you think about the limited cutaneous form of systemic sclerosis. So in terms of other symptoms, our options are alopecia, mouth ulcers, an erythematous facial rash, esophageal reflux, and erythema nodosum. Looking at the first three, you might remember that those features are usually more associated, typically, with lupus, and are not the sort of classic features that one might see in a pure limited cutaneous systemic sclerosis. Although if you do see these features, you might want to think about an overlap type of disease, which we will discuss in a future video. Looking at option E, erythema nodosum, this is not a classic skin feature that you would see in people with systemic sclerosis, and therefore we are left with option D, esophageal reflux, which you'll remember is part of the CREST acronym. Question 2, which antibody is most specific to limited cutaneous systemic sclerosis? So our options are ANA, anticentromere, rheumatoid factor, anti-SCL70, and antihistone. So actually, at least 4 of these antibodies may be seen in people with limited cutaneous systemic sclerosis, but the question is asking us which one is most specific, and the answer to that is anticentromere antibodies. ANA is usually positive in these patients, but is not specific. Rheumatoid factor may be seen. Anti-SCL70 may sometimes be seen, but usually seen in the diffuse form, as we will find out in another video. And antihistone antibodies, you will remember, are classically associated with certain forms of drug-induced lupus.
So let's do some questions now. A 30-year-old female presented a rheumatologist with a history of skin tightening in her fingers, face, neck, and legs, from the thighs down to the ankle. She's markedly short of breath and has a blood pressure of 160/114. Given the likely diagnosis, which antibody is the most specific to her condition? So you've got a young female who presents with what the case is describing as a multi-organ involvement affecting different parts of her body, and you're getting that it also has an involvement in her respiratory system. The options you've got is A, anti-SCL70, B, ANA, C, rheumatoid factor, D, anticentromere, and E, anti-Jo1. And if you recall correctly from when I was talking about this condition, which is diffuse cutaneous systemic sclerosis, you would realize that the most specific antibody is indeed anti-SCL70. Question 2, which of the following may be used as a first-line treatment in scleroderma renal crisis? A, amlodipine, B, prednisolone, C, methotrexate, D, captopril, E, piperacillin tazobactam. So this question is trying to get you to think about one of the most important both clinically and academically encountered questions, and that is the management of scleroderma renal crisis. A lot of you might have thought that if you have an autoimmune condition and if they present with a flare-up of that condition, you might consider prednisolone, as you have seen in many other conditions. However, this is not the case in the case of scleroderma, and this is something that you either know it or you don't know it, but fortunately, as you're covering the question now, hopefully when it comes to the exam on test day, you would be able to answer it confidently. And the correct answer in here would be an ACE inhibitor such as captopril.
The first question discusses a 25-year-old lady who has a history of Sjogren syndrome. She has recently given birth to a newborn who is noted to have bradycardia and evidence of first-degree heart block on their ECG. Which of the following antibodies is most likely to be positive in the mother? So the options are anti-SCL70, ANA, rheumatoid factor, anti-Ro, and anti-Jo1. So we know that she's got Sjogren syndrome, and we also know from the recent slides that we've looked at that several of these antibodies may actually be positive in someone with Sjogren syndrome, and these include ANA and rheumatoid factor. The specific antibodies you will recall are anti-Ro and anti-LAR. And pertinent to this question, it is anti-Ro that increases one's risk of having offspring with congenital heart block, which is what this newborn has, and therefore the correct answer here is anti-Ro. Question 2. Which of the following renal complications is associated with Sjogren syndrome? So the first answer is renal crisis, which we've heard about in previous videos, which is associated with hypertension. Type 1 tubular acidosis, type 2 renal tubular acidosis, type 4 renal tubular acidosis, or a rapidly progressive glomerulonephritis. You'll recall from the recent slides that we've looked at that the correct answer here is a type 1 renal tubular acidosis.
So let's do some questions. Question 1. A 40-year-old lady presents with 3 months history of butterfly rash on her face, arthralgia, puffiness of her hands and proximal muscle weakness. The GP sends the patient to the rheumatologist suspecting a diagnosis of mixed connective tissue disease. Which of the following antibodies is the most specific in this case? So the vignette is quite straightforward in the sense that it already gives you the diagnosis that the GP is suspecting, quite rightly so, in this patient. The options that you've been given is A, SCL70, B, ANA, C, URMP, D, anti-Rho, and E, Jo1. And if you remember, I mentioned to you earlier that the most specific antibody to mixed connective tissue disease is anti-URMP. You indeed do get a positive ANA in virtually all of the cases of mixed connective tissue disease. However, that is not the most specific antibody. Options A, D, and E have been covered in previous episodes, and they are the most specific antibodies to other conditions, which you're welcome to go and see our previous videos to refresh your knowledge on. Let's do some questions. Question 1 is a 40-year-old lady presents with 3 months history of progressive symmetrical muscle weakness affecting her upper arms and thighs. She attends clinic in a wheelchair as she finds it increasingly difficult to get out of chairs once seated. She has no rashes, fevers, or weight loss. She has noted some mild shortness of breath, and her CK is 15,000. Which of the following antibodies is most specific for her condition? So right off the bat, you need to be very comfortable with this clinical vignette because it's quite classically describing a case of somebody who could have a diagnosis of myositis. Importantly, they're telling you that she has a very elevated CK that you would not be getting in a case of polymyalgia rheumatica. So really it comes down to knowing your myositis specific antibodies. The options you've got is A, SCL70, B, ANA, C, anti-CCP, D, anti-Rho, and E, anti-Jo1. And if you were paying attention earlier, you would realize that the correct answer would be option E, which is anti-Jo1. Option A, B, C, and D are all other important autoantibodies in rheumatological diseases and are quite MRCP favorite, and we have discussed all of them in details in our previous videos. Please feel free to go and watch those to refresh your memory. Question 2. A 30-year-old lady is given a new diagnosis of polymyositis after presenting to the rheumatologist with symmetrical proximal muscle weakness and a raised creatinine kinase of 10,000. Which of the following should be given as a first-line treatment? So this is asking you about the treatment of polymyositis. It's already given you the diagnosis, and the options that you've got is A, rituximab, B, corticosteroids, C, ibuprofen, D, hydroxychloroquine, E. adalimumab. You will realize that at least 2 of these options are used in management of polymyositis, and those are corticosteroids and rituximab. However, we do use corticosteroid as a first-line treatment for this condition, which is what the question is asking you. And in refractory cases only, we will be using rituximab.
Question 1. A 50-year-old gentleman presents with 2-month history of rapidly progressive symmetrical proximal muscle weakness. He has a rash over his arms with erythema and swelling around the eyes. He has lost approximately 2 stone in weight in the same period and has noticed some shortness of breath. He is a smoker of 25 years, smoking 15 cigarettes per day. Blood tests show a new anemia, raised ESR and CRP, raised adjusted calcium, and a CK level of 20,000. He's also noted to be ANA positive. A myositis screen is done and it comes back positive for anti-TIF1 gamma. So what is the next most appropriate investigation? So this is a vignette with a lot of information. This gentleman has a smoking history that's quite extensive, and he's presenting with a myriad of symptoms, including weakness in the muscles, a rash over his arms, and this erythema and swelling around the eyes. And if you look back at the slides, you may feel that this may be consistent with a heliotrope rash. He's also had some weight loss and he is short of breath, and several of his blood tests are abnormal, particularly that CK level. You'll also notice that he's got antibody positivity for TIF1 gamma. So we have a few options here. They are chest x-ray, PET-CT scan, colonoscopy, ultrasound scan of the hands, and a skin biopsy. Now, of course, we would want a little bit more information, such as a fuller history, and to examine the patient. And depending on what we may find, all of these tests may be relevant at some stage. So patients may undergo a skin biopsy for their rash in dermatomyositis. If the patient is complaining of bowel symptoms, along with his weight loss and abdominal pain, then a colonoscopy may be prudent. If he's got arthritis or joint swelling on examination or on his wider history, then an ultrasound scan of the hands may also be helpful. And indeed, a lot of these patients do undergo PET-CT scanning at some point. We can see from the history that he does have a TIF1 gamma positive dermatomyositis. So what we really need to exclude here is some form of malignancy. And given his smoking history and that new shortness of breath, the most important thing to do immediately would be a chest x-ray to exclude this. But as I say, some of these other tests particularly may be needed in the future, but in the immediate setting, the chest x-ray is most important. Question 2. A 30-year-old lady is given a new diagnosis of dermatomyositis after presenting to the rheumatologist with profound muscle weakness and a rash over her knuckles. ANA is positive. Which of the following other antibodies is most specific to this diagnosis? So we can see that she's presenting with dermatomyositis, and that rash that's described is possibly the Guttrun's papules. She's ANA positive, but she also has something positive quite likely on her myositis screen. So let's look at the options. Our options are rheumatoid factor, anti-CCP antibodies, ANCA, anti-MY2, and anti-parietal cell. So you'll remember from the previous slide that anti-MY2 antibodies are most specific for dermatomyositis. There are many antibodies that may be associated with dermatomyositis, as we discussed. But the most common for this rare condition is anti-MY2, and the one that's most likely to be asked about. We have heard about some of these other antibodies in previous episodes, and we'll be discussing some of them in future ones as well.
So let's do some questions. So a 50-year-old sailor presents with a left swollen calf. He is found to have positive antiphospholipid antibodies. Which of the following statements is correct? So the statements are: he can be diagnosed with antiphospholipid syndrome straight away. Positive APS antibodies may lead to a false positive syphilis VDRL test. Antiphospholipid syndrome cannot be diagnosed in males. Apixaban would be indicated if APS is confirmed. and a positive D-dimer is diagnostic of a DVT. So the correct answer here is that a positive APS antibody test may lead to a false positive syphilis VDRL test. So this is quite a tricky question, but it is possible to work out the answer, as is the case with many MRCP and MCQs, by first of all eliminating the ones that we know are wrong. So taking the first answer, which says he can be diagnosed with antiphospholipid syndrome straight away, we know this is not true because the antibodies have to be positive on more than one occasion 12 weeks apart, and as far as we know from this vignette, they've only been tested once. So we can eliminate number 1. Number 3 says that antiphospholipid syndrome cannot be diagnosed in males, which is also false. It can affect males and females. Number 4 says that apixaban would be indicated if APS is confirmed. This is not true. Warfarin is the first line of treatment if someone has had an event and they are found to have antiphospholipid syndrome. And we know that a positive D-dimer is not diagnostic for DVT, and there are several reasons why this may be raised. So this leaves us with the second answer as being correct.
Let's do a question. A 20-year-old tourist from India presents to the emergency room with 2-day history of confusion and bilateral erythematosus rash over the shins associated with ankle pain. Given the likely diagnosis, which of the following statements is not correct? 1. Tuberculosis must be considered as a differential diagnosis. 2. Serum calcium is likely to be elevated. 3. In the presence of intracranial involvement, treatment with steroid is indicated. 4. The rash on her leg should completely resolve after treatment. 5. PET-CT needs to be considered as part of acute management. So hopefully by reading that scenario, you have gathered that this case is trying to hint you towards a potential diagnosis of sarcoidosis. And hopefully you have gathered that the rash on the leg is erythematosus. As you recall, we said that the biggest differential in a case of sarcoidosis is actually tuberculosis. And that's why you really want to get the biopsy to differentiate between non-caseating granulomas in sarcoidosis versus the caseating granulomas in TB. You may also recall that the biggest biochemical abnormality in sarcoidosis is actually elevated serum calcium. And having elevated serum calcium that's not responding to dietary calcium restrictions is actually an indication to treat sarcoidosis with steroids. Option 3 is telling you that in the presence of intracranial involvement, treatment with steroid is indicated, and that is correct. Because, as you recall, ophthalmological and cranial sarcoidosis are two of the body parts that very frequently are actually treated actively with corticosteroids. Option 4 is telling you about the fact that erythematosus actually does completely resolve after treatment, which is true. And therefore, option 5 is going to be the correct option here, which is the incorrect statement. And that's PET-CT may be considered as part of the acute management, which is incorrect because PET scanning in sarcoidosis is towards treatment and response to treatment, and it's not something that you would be wanting to look into in more details in terms of acute management of sarcoidosis. Thanks for listening to this episode of PACES MRCP. If you like what you've heard today, give us a thumbs up and hit the like and subscribe button below to make sure you don't miss our next episode. Let us know in the comments which topics you would like to hear in the future. See you in the next episode.